Okay. Thanks so much again. My name is Lynn Hernandez, and I'm with the Desmoid Tumor Research Foundation. It's great to be here with you today for our webinar about the classification of desmoid tumors. Just so you know, this event is going to be a conversation. There will be no presentations during this webinar. So back in February of 2025, DTRF launched a campaign to spread the word that desmoid tumors are not benign. This campaign seeks to educate the community and the broader public that the World Health Organization classifies desmoid tumors as intermediate grade soft tissue tumors, not falling into the classifications of benign or malignant. We're excited to host this event today with three main objectives for you. First of all, we want you to learn from an expert clinician about the classification of desmoid tumors and the language associated with it. We want you to hear the experience of two people living with desmoid, along with the journey and challenges when the disease is not described accurately. And then we also want you to understand the importance of consistency in language when discussing desmoid tumors. Okay, so I have three guests with me today. I'm going to introduce you to all three of them. The first is Dr. Raveen Ratan, who is Associate Professor in the Department of Sarcoma Medical Oncology at MD Anderson Cancer Center. He has a large clinical practice focusing on the treatment of patients with sarcoma and other connective tissue neoplasms, including desmoid fibromatosis. Dr. Ratan is a passionate educator who lectures to medical trainees at multiple institutions regarding the management of sarcoma, and he facilitates their involvement in the care of patients at MD Anderson. He's also a frequent speaker at patient and caregiver education events throughout the country. Today, when Dr. Ratan speaks with us, he's going to be speaking from a clinician's perspective. Our next guest today is Deanne Sorensen. Her journey with desmoid tumors began in 1996 when she received the life-altering diagnosis of a desmoid tumor in her left leg. In 2012, she became the administrator for the Desmoidian Facebook group, which has evolved into an international support group currently standing as the largest of its kind. The group was created as a place to connect with other patients with the belief that no one should endure the challenges of this disease alone. In 2023, she co-founded the Desmoid Project, a nonprofit that focuses on the mental health and well-being of desmoid tumor patients. Deanne will be speaking from a patient perspective today and as someone who interacts regularly with patients who are actively facing challenges with desmoid tumors. Our final and third guest, Dr. Alex Somaya, who is a desmoid tumor patient who previously was Senior Director of Clinical and Translational Research at the Association of American Medical Colleges. He also has served as a researcher for the Defense and Veterans Brain Injury Program and at National Institutes of Mental Health. Dr. Omaya received his Doctor of Science degree in Health Policy and Management from Johns Hopkins and master's degree in biopsychology from Mount Holyoke College. Alex will be speaking from the perspective of a patient, and also he has a lot of experience in research as well. So all three of you, thank you so much for taking the time to join us today. What's so great about this panel is that each of you is an expert in the same topic, but from different perspectives due to your experience and relationship with desmoid tumors. Okay, so let's just talk about quickly how we're setting this up to our attendees. If you have questions for our panelists, you guys are going to see that the Q&A is open. If there are questions with regard to the topic of classification, please put those questions in the Q&A. If you want to share your personal experience with desmoid tumors, please use the chat function. This is not going to be monitored. You can share your personal experience about the disease. If you have questions unrelated to today's topic, please reach out directly to the foundation at info@dtrf.org, and we will do our best to direct you. Please note that this webinar is going to be recorded. It will be accessible at the DTRF video library on dtrf.org. Okay, we got all that business out of the way. So as we move on into this big topic, we're going to ask for some background for framing purposes. So this question is for Dr. Rattan. Dr. Rattan, can you please describe the definition of desmoid tumors according to the World Health Organization and the National Comprehensive Cancer Network?
Sure, happy to do it. And Lynn, thank you for having us today. Thank you to the DTRF for everything you do for the community, and really happy to be here with my co-speakers, Alex and Deanne as well. So this is great. Thanks for having us. So yeah, I'm happy to talk about that, but I think it's helpful to maybe zoom out a little bit first. So, when you talk about classification of tumors in general, right, and that could be anywhere in the body, on the medical side, that's typically done by pathologists. These are people that are accustomed to looking at patients' tissues, either in a biopsy or looking at the genetics when we do additional testing on tumors, and basically giving that tumor or that growth a name. Okay, sort of what is it? And that name then can inform to a clinician sort of how that growth or that tumor or that lesion, as we might call it, is likely to behave. So that classification exercise is kind of the first step whenever you're treating somebody with any kind of growth, okay? And so the WHO, or the World Health Organization, routinely convenes panels of experts to do this work. So in 2020, they convened a panel of soft tissue pathologists to update the classification of masses, growths, lesions, we would call them tumors, that occur in soft tissue. And soft tissue is basically the parts of the body outside of organs. So things like your muscles, the fat, your legs, your arms, your body wall, not in organs. That's really what we mean when we say soft tissue as clinicians. And what they did in that 2020 classification is they put soft tissue tumors into 11 buckets that are based on what kind of tissue they come from. So there's tumors of fat, tumors of blood vessels, et cetera, et cetera. And there's one one bucket that matters for our sort of discussion today, which is fibroblastic and myofibroblastic tumors. Fibroblastic basically means connective tissue or almost scar. So these are tumors that originate from that type of tissue. And within each of those buckets, they actually make sub-buckets that tell you a little bit about how the tumor is likely to behave. And so those categories are things like benign, which is typically a tumor that once removed is not likely to come back. And the subtext is most benign tumors don't grow or grow very slowly. There's locally aggressive, which is where desmoid tumors come up, and that's where I'll come back to that in just a moment. There's rarely metastasizing, which means tumors that most often are going to be a problem where they may grow, but they're not likely to spread. And then there is malignant, or more likely to metastasize, which is what we think of when we think of cancer that's likely to spread to other parts of the body and may often in that way threaten a patient's life. So what does locally aggressive mean? Locally aggressive means that the tumor may grow where it is. It may recur after surgery. It may cause damage to adjacent structures, and that's something that we see frequently with desmoid tumors. We'll see them narrow blood vessels or restrict motion or cause swelling or cause pain. But what desmoids will not do, which a classically malignant tumor can do, is spread in the bloodstream to other parts of the body. And I think that's kind of a defining characteristic. The other thing that we see with desmoids that is different from truly malignant lesions is that they don't always grow. Kind of one of the subtexts of calling something malignant is that you expect that without an intervention, it will continue to get worse. Desmoids do sometimes get worse, and we see many patients who have consequences from that. But they also sometimes will stop growing on their own. And what we've learned in recent years is that many desmoids, without intervention, without us doing anything in terms of treatment, can even stop growing and shrink on their own. And I think that's a key differentiator. Now, part of our discussion today is focusing on how the benign word can significantly understate the experience of patients with these tumors. And I think the use of that word comes from sort of a lack of precision out there in the community. These are rare tumors, right? And when you are telling someone that they have a breast biopsy and it came back benign, you're basically saying it's not a cancer. You're not accounting for these intermediate entities that can be locally aggressive, problematic, um, even though they're not going to spread the way that a cancer typically would. Um, and I think it's important that we try to get this right, because I think that benign word also lends itself to sort of statements about treatment. And we also see that many patients with desmoids, even in 2025, when the field has sort of moved forward, are being told that, well, it's benign, you just need surgery, and that will be the end of the story, when we know that for many patients with desmoid tumors, that's not true. And so part of that is incumbent on us, sort of experts in the desmoid community, to educate our colleagues out there in general practice who see these tumors very infrequently. That benign is not the right word, that they can be associated with real consequences for patients, psychosocial distress, pain, discomfort, and in fact, surgery by itself is not always the answer. And so I mean, that's a challenge for us, but one that we continue to try to work on as we develop new therapies for the disease. But I'll stop there and let others chime in.
Quickly, on the heels of that, Dr. Ratan, before we move on to Deanne and Alex, can you share your experience when desmoid tumors are described as benign in clinical practice?
So, I think you see impact in both ways. Okay. So I think when people come to see me, I work at a cancer center, right? The patients who are seeing me are in the same waiting room as people that have a life-threatening diagnosis that is likely potential or that may end their life in the coming weeks or months. That is true for a segment of patients with desmoid tumors also. And you never want to forget that it is life-threatening for a segment of patients. But one of the first things I'm often educating patients about is that this is not a malignant cancer. This is not going to move from your leg and spread to your brain, for example. And that's a fear that I see some patients have. And so they are relieved to hear that that's not what they have. On the other end, you have people who are really suffering as a consequence of having this disease, right? They may have restrictions of range of motion. They're not able to do something they want to do in their regular life. And then when they are told that that is benign, it can feel, and that you are sort of understating the impact of this condition on that person's life. And while I often think that clinicians use the word benign without sort of the baggage of saying it's not a problem, I think sometimes patients can hear you're telling me that this isn't something I have to worry about, but it impacts my life day to day. So I see reactions in both ways, and we try to be very precise with the words that we use. This is not a cancer, but it can still be a problem. It may or may not be a problem for you. And that's kind of what we try to establish the first time I meet a patient.
Thank you so much. That's great. So Alex, as a patient, can you share what you've seen and experienced when desmoids are described as benign?
So I can just tell my own story because I think it relates to that. So basically, I had an appointment with my endocrinologist. I'm a type 1 diabetic. And, I had sort of this hard area around my abdomen. And so I was asking her to investigate that. And so we had a scan. The scan came back and there was a large, tumor, which was identified. It's about soccer ball sized, 20 by 20 by 16 centimeters. So what caused some concern is that, one, it was large, but the other thing, it was pressing against the superior mesenteric artery, which is a major vessel, and, in a sort of a bad location because it was, touching other organs, and they weren't quite sure what the issue was. So from the perspective of the surgeon who I later saw, and the interim sort of discussion among doctors. So basically, my endocrinologist had a discussion with a variety of doctors. I was at a sarcoma center, so they spoke with folks who specialize in desmoid tumors. The sort of the group of them decided that immediate surgery was the best approach, and this was in 2019. Before the consensus paper was out. And I would say some of the literature has changed since then. More sort of more active surveillance is sort of suggested as a first line of treatment. But anyway, in my case, The tumor appeared encapsulated, so the surgeon, was excited to remove it. And he told me, this is a benign tumor. It looks encapsulated, it looks well described, looks like we can get it out. So, let's go ahead with the surgery. So in my mind, even having a background, in research and looking at healthcare issues for most of my career, I thought, oh, this is fine. It's a big tumor, but it's benign. They'll take it out. So, the tumor sort of arose from the mesentery. So when they did the resection, a lot of the mesentery, essentially was removed. And part of the problem with that is the mesentery, it's actually considered an organ, but it's a membrane that contains blood vessels and lymphatics and nerves and secretes fluid, does a variety of things, an important thing, but also holds it in place, right? So holds your intestines in place. So when they removed it, they removed some of the vessels, and of course that meant some of the intestine had to go. Also, the tumor was attached, and there was infiltration in the intestine and part of the stomach. So what did that mean? It meant that the resection removed 80% of my small intestine. So I now have what's called short bowel syndrome, 25% of my stomach and 25% of my large intestine, and also the valve that connects the two pieces, the small and large intestine, called the ileocecal valve, which is important because that sort of plays a role in diarrhea for me. So that's sort of, the biggest problem, or one of the biggest problems I have. So I lost the greater curvature of the stomach, all of the small intestine except for sort of the jejunum, which is the middle part of the small intestine, and the portion of my large intestine, as I mentioned. So the surgeon sewed the two portions of the intestine together, which is called anastomosis, so to create, a new connection for me. So when I, woke up from the surgery, we had some discussion of it. I didn't really understand all the implications, but what it means is, I've got malabsorption of food and water, lots of diarrhea. So I have diarrhea about 8 times a day. So ever since I've had this surgery, sometimes more than 8 times a day. I have to be very careful about my diet. I was originally on total parenteral nutrition, which is essentially is IV feeding, right? I was on that for some time. I was happy when I got off that so I could, eat food. But the challenge is, the diet is a low fat, low sugar, low fiber diet, kind of a boring diet. Think like white bread and rice kind of thing with some protein. Um, so, so that's sort of the big thing. The other thing is that, had desmoid tumor, as Dr. Rattan mentioned, some people, it can be a very serious, condition. But, now I have a sort of a mortality rate associated with my short bowel syndrome condition. About 35% of people after 6 years in the community, die. So, and over time, it can be a problem for complications. So also, when the tumor was resected, it recurred. And so now I have 6 index lesions. I have some other lesions. The index lesions are the larger ones. And one is still on top of my superior mesenteric artery, and sort of the radiologists say it's intimately associated with the artery. So I didn't even fix, the main issue that sort of led me to the surgery in the first place. And so I'm in my 5th year of taking sorafenib for the recurrent tumors, primarily because of the SMA, the Superior Mesenteric Artery Association, and we watch that carefully over time. So the benign, in my case, the benign label sort of led me to a framework that said, well, this is probably the way to go here, because I was thinking of benign, as most people do, as not including recurrence, which desmoid tumors have, and not including the infiltration, which also desmoid tumors have. So they can cause a lot of damage. So just wanted to give my story as an example.
Thank you so much, Alex. Deanne, as the administrator of the Desmoidian, can you share what you've seen and experienced when desmoids are described as benign?
Well, of course I can. I will start with my story also. Um, I was diagnosed in 1996 with a desmoid tumor in my left leg. I was 25 years old, working at a mortgage company. I had two very small kids. I had a 3-year-old daughter and a 1-year-old son. After a couple of misdiagnoses, I was scheduled for an outpatient surgery to remove my tumor. What actually ended up happening was I had 6 extremely complicated surgeries to remove my tumor. I ended up getting an arterial bypass along with a venous and nerve transplant because the tumor had encapsulated the vital structures and the tumor could not be removed without sacrificing them also. Tumor was about the size of a fist. All of the vital structures ran through the center, so they had to cut above and below, remove the tumor, and then rebuild everything in its path. Amputation was suggested at that time, and I fought against that. Following surgery, I had every complication that you can think of. The worst complication was when I went into kidney and liver failure. I spent a month in the hospital for what was supposed to be the outpatient surgery. And I spent over a year unable to walk without using crutches. I ended up getting pregnant with my youngest daughter when I was at my unhealthiest point in the battle. And I have to say, raising 3 tiny kids and being sick and struggling for mobility every day is really hard. In 2011, 15 years later, I thought my battle with desmoids was over. I started noticing that the color of my leg was changing, and I asked for a scan. It was denied. I asked to see the vascular surgeon that had rebuilt the vascular structures. I was denied. So I spent a year trying to get insurance approval for an appointment with my vascular surgeon. I don't think that that would have happened if this disease had a clear definition and treatment protocols to follow. My vascular surgeon found 2 recurrent tumors. One is in the same spot as the original tumor, and the other one is a little further down in my calf. I had not understood the importance of getting yearly MRI scans, and honestly, probably couldn't have afforded it anyway. At this time, they also recommended that I have an amputation. I chose to try medications instead, and that was successful for me. Currently, I still have 2 tumors. I am paralyzed from the knee down, and I have less than 50% circulation in that limb. Tons of things have changed since that time. One thing that has remained really consistent is that patients are confused. We are confused about how to classify the disease that we have. This may not seem like a big deal to a lot of people, but it actually causes a ton of stress for patients. Like Lynn said, I run a Facebook page called The Desmoidian. We have over 7,000 international members. They are patients and caregivers from all over the world. They come there looking for information and support. Since desmoids don't actually fit into the binary categories of malignant and benign, and not all physicians are well versed and educated in this disease, some patients are told malignant and some patients are told benign. My medical chart actually says that I have a malignant neoplasm. This causes confusion and arguments in the online patient support group. There are debates about once a month, just going back and forth about how to classify this disease. I have listened to thousands of patient stories. It seems that patients who are told that their desmoid is benign believe that they can have a simple surgery and be done with it. Patients don't know that the tumor can be a lot more infiltrative than it appears on their scans. They end up getting much more invasive surgery than anticipated, with unexpected complications followed many times by recurrences. A lot of these surgeries, like mine, are mutilating. There are definitely patients that go in, have a surgery or treatment, and then never have a recurrence. There are also patients who have spontaneous regression. These lucky ones don't really stay and hang out on our Desmoidian Facebook page. So I don't hear their stories as much as I do the other ones. In my experience, and from many of the members in the Desmoidian page, uninformed doctors can underestimate the unpredictable nature and the challenges that come with a desmoid. And it seems like patient outcomes are worse when their physicians consider a desmoid tumor benign. These tumors can be life-altering, and it's terribly invalidating. Dr. Rattan touched on this. It's really invalidating to go through all of the available cancer treatments like chemo, radiation, ablation therapy, amputation, or mutilating surgery, and then be told that you have a benign tumor. Patients don't feel like they belong anywhere. We don't fit into a box. And the reason that I am so thankful that we are doing this webinar is because I feel like it's so important for patient care and for patient outcomes that everyone starts using the same terminology just across the board. I believe that not having consistent language is hurting patients physically and emotionally. Thank you.
Thank you, Deanne. So I just want to say that we are over in time. So we're going to see what we can do as far as trying to get as many questions answered as possible. But I just had one other question that I wanted to open up to three of you, and whoever wants to speak up can. We'd like to hear whoever wants to share about your challenges in communicating the definition of desmoid tumors, whether it's to patients, family members, other clinicians in clinical practice. Feel free to share, whoever wants to speak up.
So I'll take a quick stab at it, but I think I'd be interested in Deanne's input as well, because I'm sure that I'm sure this is a topic of discussion that comes up frequently in the Facebook group, right? So, I mean, what I usually tell people is that this is what's called a locally aggressive tumor, and I tell patients that the future for you is uncertain, right? And for some patients, we're not going to treat because they don't really have symptoms. It's not causing them difficulty, and that may be you, in which case we will watch you closely for a period of time and less closely over a period of time. And this may not be something that severely impacts your life. And I think it's important to say, especially given sort of Deanne and Alice's experience, that is common in the desmoid space. And as Deanne also said, those may not be the patients who are always seeking support in online groups or in the community, because for them it ends up being a footnote rather than a focal point for an episode of their lives. But it's something that we see a lot, right? When you're sort of seeing just sort of the spectrum of patients with desmoid tumors. So I say this is a local aggressive tumor, and what it means to you is really going to depend on whether you're having symptoms and what it does going forward. And so if you're not having symptoms, we're going to watch this, and it may just sit there or get better. It often does. If you are having symptoms, or if it's near something that's life-threatening, this can be a locally aggressive tumor. It can cause problems in the neighborhood, even though it's unlikely to spread. And we're going to take it very seriously, no matter which of these paths we choose. We're not taking anything for granted. And I think trying to sort of communicate, one, that this is not a cancer that for most patients, and that is an important caveat, for most patients is going to be life-threatening, but is still something that is worthy of attention, is worthy of care, and that could be impactful for you. And so we need to take that seriously. I try to sort of walk that line of communicating both of those realities, recognizing that for different patients, they're going to fall different places on that spectrum. And I don't always know the first time I meet them where they're going to end up.
So
So
go ahead, Dean.
Oh, you can go ahead, Alex.
Okay. So I'm treated at 3 academic medical centers, and I often hear providers who are not, specialists in this area or ancillary staff just, tell me it's a benign tumor. And usually I take the time to say, it's classified as an intermediate tumor. And primarily this is because of the recurrence potential, but also its infiltrative potential. And sometimes we'll have a short discussion afterwards and sometimes not. But I think it's helpful, at least from my perspective, to, when it comes up, to just, give my thoughts about it and have a discussion if one happens. Certainly willing to do that. So I would just say it comes up all the time in the clinical environment from my experience.
Yeah, and I would have to add that, like, I've had this disease for 29 years, and it is still extremely hard to explain to people what I have. I answer the questions differently, whether I am talking to a physician or whether I'm just talking to family and friends. If I'm in a physician's office, like brand new doctor, first time, not an oncologist, I know that these guys probably don't have any idea what I'm talking about. But I need them to understand that I have something that they need to take seriously. I need them to know that I have a complicated medical history. But on the intake form, it's, when you're filling out all the forms, there's not a spot for me to fill things out. And what I usually end up doing is writing, anywhere that there's room, that I have a desmoid tumor. And then I will further explain that it is a non-metastasizing soft tissue tumor. And at that point, I assume that they'll look something up. I don't think they do. I've been corrected and told that I have a dermoid. And then you have to have this, no, I'm really not stupid conversation. I do know what I have. And so it is really frustrating. When I'm talking to family and friends, I just try to condense everything. A lot of people know what a sarcoma is. So I will say I have a non-metastasizing soft tissue sarcoma. It's the shortest, simplest version that I can come up with. And I know that desmoids aren't truly a sarcoma, but we are treated under that sarcoma umbrella. We're treated at sarcoma centers by sarcoma specialists. And so that seems to be the box that I want to put it in, because I feel like I need to put it into a box for people.
Okay. Okay, so thank you for that. We're going to move into another section of the webinar, and these are discussion questions. So now I'm going to pass the baton over to Deanne and Alex, and if you guys want, you can pose some questions to Dr. Rattan.
Dr. Rattan. Desmoid tumors do not metastasize. For this reason, some sources will inaccurately use the term benign when referring to desmoids, presumably because benign is a common term for a tumor that does not metastasize. However, a benign tumor, by definition, is slow growing, has distinct borders, and does not invade nearby tissue, does not recur, and is generally not harmful. In my experience, desmoids definitely do not fit that definition. Why do some physicians and sources continue to use the term benign, and how can we get them to change to use the World Health Organization definition of an intermediate grade tumor?
It's a great question. I think sort of the theme of our conversation. Thanks for posing it. I think we physicians and nurse practitioners and other people that provide care to patients are all people, right? And we all sort of function the way that people do. And these are extraordinarily rare diseases. So if you are let's not even say a primary care doctor, let's say you're an oncologist or a surgeon in general practice, that benign and malignant paradigm serves you very well when you're talking about a breast cancer, or a prostate lesion, or a lump under someone's skin, which most often is a benign tumor called a lipoma, and that's what you see every single day over and over again. And you may encounter a patient with a desmoid tumor once or twice or three times in your career, right? Depending on sort of what your focus is. And so you apply the paradigm that works in most of those situations. And I think it's incumbent on us whenever we are talking to clinicians and co-managing patients to say, well, actually, in our classification of these rare tumors, there is an in-between category, this locally aggressive bucket where desmoid tumors fit. And so we don't call this benign. We don't call this malignant. It is a locally aggressive tumor. And I think that every single patient's experience is different. There are patients for whom the desmoid tumor, not medically, I'm not using the word medically now, but in sort of the total course of their life, ends up being a benign episode. They have something that they become aware of, it never caused symptoms. They either watch it or they have a cryoablation and it goes away. And for them, their perception of that disease was that it was very benign. And then, as both of you have eloquently shared and others are talking about in the chat right now, that is not everyone's experience, right? And so that locally aggressive that locally aggressive sort of terminology, I think, allows us to sort of acknowledge that both parts of this can be part of the experience for patients, even though a given patient is only going to have their experience with their tumor and their disease.
Thank you.
Thanks, Dr. Rattan. So my question relates to explaining the difference between multifocal tumors, which desmoids can have rarely, or tumors which metastasize.
Yeah, it's a great question, and others actually asked for it in the Q&A, and I apologize for not getting everyone's questions because I've been also trying to listen to my incredibly eloquent co-speakers. So metastasis is kind of a specific process when we talk about cancer, and it denotes tumors that basically shed cancer cells into the bloodstream, and those cancer cells then travel in the blood to distant parts of the body, right? That's what a metastasis is. And desmoids, generally speaking, the vast majority of the time do not do that. And I'll talk about why I put those caveats in a second. But we do see some patients that have more than one desmoid tumor, right? And I think they tend to fit into two specific groups. One is patients with an underlying genetic condition called familial adenomatous polyposis. This is a cancer. This is a mutation that exists in every cell in a person's body that predisposes them, makes them more likely to develop colon cancer, and that's what we see most frequently in those patients. And then also they have a much higher risk of developing desmoid tumors, very often in response to trauma. So if they have a surgery, they may develop a desmoid tumor at the site of that surgery. And so we see patients with FAP that will have multiple desmoids, very often inside the belly, because as part of that disease, many patients have their colon removed in young adulthood. And then that surgery itself may sometimes spark desmoid tumors. I've also seen patients develop them after cesarean sections, for example, giving birth to their children, et cetera. Then you have patients that don't have FAP, but still appear to have multiple desmoid tumors. Very often they're in one neighborhood. So you'll have desmoid tumors, for example, going up and down a patient's leg, or in one part of the pelvis going down one leg or one arm into the chest wall. And what we think is typically happening there is not that you have multiple tumors that are all separate from each other, but you sort of have a process where you've got a tumor with tendrils or webs that connect these things, even though you may not be able to see those on imaging. So that multifocality is not that it's spread from one part of the body to the other. It's that they're connected. It's just not visible that you can see that. And that's kind of why they tend to cluster in one part of a person's body. Every once in a while, we meet someone who's got a desmoid in the shoulder and another one in the buttock and no genetic predisposition for that. And I am not able to explain why that happens, but there are people like that out there. And some have asked questions about that in the chat. That's a very small minority of desmoid patients, but we do encounter people like that as well.
Thank you.
So some of these it's a little redundant because we're on the same topic. Comments from many patients within the desmoidian indicate that there is not consistent language among physicians on the definition. Therefore, many patients' treatment pathways don't seem to follow the NCCN guidelines. When patients are told that the disease is benign, they underestimate the potentially aggressive course of desmoids and the need for long-term follow-up care. These patients are also not given an option to be seen at major sarcoma centers. Do you have any suggestions for improving the connections and knowledge transfer in the medical in the medical community along with the patient community. You're muted.
Yeah, I knew. I just wanted to make sure you knew. So it's an ongoing discussion, right? So one thing that I said at the beginning, and I think both of your stories nicely sort of illustrate, is that the way that we care for patients with desmoid tumors has changed dramatically in the last 10 years. Surgery, which used to be what everybody got, is now only very rarely recommended at most sort of specialty centers, in part because tumors can recur and because surgeries can cause complications, as both of you shared in your stories. And so we've tried really hard to teach people, surgeons that trained at top-notch cancer centers 8 years ago, were taught that desmoid tumors are surgical unless otherwise directed. And so we've done a few things. And so, Alex referenced a consensus statement. So there was a consensus statement that I believe was done in 2018, I want to say, and that was updated again last year, which describes the behavior, describes the current state of the art, and the current thinking about how these should be treated. Now, a consensus paper is only good if people know to look for it.
Mhm.
I think that we've done our best to we've presented at national surgical meetings to sort of give the message of, hey, the management of these diseases has changed, and so people that go to those meetings hear about it. I will say for desmoid tumors, the patient groups, the DTRF and other groups around the world, not just the United States, have been instrumental, right? I think in organizing the community. I would say that desmoid tumor patients, not all of them, are some of my most well-informed patients, and that's because in 2025, the first thing you do when you're given a weird diagnosis is you Google it.
Yeah.
And one of the challenges there's a lot of information. Some of it's reliable, some of it's not. I think, patient groups and patient forums have always been helpful, but as you mentioned, Deanne, the people who tend to hang out are the people that have struggled the most with the disease, and it can give people um, an accurate sort of view of the disease for a segment of the population, but not the whole population. And so people will conclude that that's going to be their story. I remember this from when my wife and I were struggling with a pregnancy complication, where if you ever Google a pregnancy forum, you'd be surprised that people ever make it through a pregnancy, right? So, so I think that we worry about that. So I think the DTRF has also directed people to some of these resources, and we've handed the consensus statement to patients and said, share this with your doctor. This is the current state of the art put together by a diverse group of people that all really care about management of this disease. And so I think those are the things that we're doing. It is not enough. And the part of the challenge is that for a rare disease, people only pay attention when they have a patient in front of them with it. And so part of it is to use that encounter, to use each of you as an opportunity to educate your care team.
Yeah. You'd be surprised at how many patients within the page are still being told surgery as a first line. And it's because doctors are just they haven't caught up yet.
And that's not a never, but if surgery is being recommended, you should really ask questions about whether that's the right thing. And sometimes it may be, but you should ask questions about that.
Yeah. Yeah.
So a question came up which sort of caught my attention, which is, about those who are essentially in, watch and wait, active surveillance. And, they're having sort of growth, but it's not being identified as growth because it's less than 20% on the scan. So it's sort of slow growth over time, right? So this one patient in the chat told the story essentially of, we watched it for a year and a half, and actually it grew, pretty very much larger during the period, but slowly. So there was no active treatment. And now, we're sort of addressing a tumor that is in worse shape than where we started off in. And there's that sort of issue. And the other thing I think about is, it's not in the guidelines, but we know that something that's greater than 5 centimeters from the literature, you're at higher risk of a poor outcome. It used to be 10 centimeters. The recent consensus paper identified 5 centimeters. So, you sort of want to think about that as well. So tumor size and, active surveillance. So I guess my question relates to when you're monitoring a tumor, what's sort of your thinking? I mean, obviously the location of the tumor is important. There's a whole variety of factors you have to take into account. But what would you do in those sorts of circumstances where we're seeing slow growth over time, where you're seeing maybe a larger tumor that's in a challenging location, would you sort of at that time think about treatment?
So, I think a question that we get asked a lot by patient groups, by even, industry groups, people who are trying to come up with treatments for the disease is sort of, well, who do you treat? How do you know when it's time to treat somebody with a desmoid tumor versus active surveillance? And this is not standardized, right? And you're going to see different recommendations. The general thought process for me, right, is first question is, does the patient have symptoms? And are those symptoms worse than the symptoms I would cause with treatment? Right. And so if all we had for a desmoid tumor was really, really toxic drugs, then the threshold to treat would be higher because I'm going to make the person feel worse than they do. As it turns out, we have some medications now which can be, although they aren't always, but can be very well tolerated. And that's been very advantageous. And as a result, we sometimes treat patients that we may not have in the past. We have cryoablation, which can be low risk, but you have to have kind of a Cinderella tumor that's in the right spot, that's the right size, that's not next to things that would be harmed by the procedure. So you're always trying to say, okay, well, is the tumor causing a problem? And usually that's symptoms, although the other possibility is what I call pending anatomical complications. Is it about to cause a bowel obstruction? Is it about to cause a blood vessel to become constricted? That would be another reason to treat, even if a patient doesn't have symptoms, right? But that's not strictly defined. That's a judgment call that I make in clinic, talking with the patient about their priorities. Most patients these days do get active surveillance, even large tumors, depending on where they are. A 7 centimeter tumor in someone's thigh, if it's away from blood vessels and nerves, may be observed. A 7 centimeter tumor in someone's neck is not going to be, right? So that location matters a lot. And then, patients' comfort with that approach is important too. I do try to educate people that this does not have to be treated, right? And it's really a question of what's it doing for you. And we try to separate that from sort of the very understandable concern that comes from just having a mass on a CAT scan, right? Whether or not it's actually causing problems in that moment, that's scary, right? And so some of it is education about the fact that, even though it's there, it may not necessarily be a problem. And sometimes making it go away could cause more problems than leaving it where it is. So you try very hard to select patients that are not likely to get worse, even if the tumor grows a little bit. Alex, you alluded to a 20% number. That is used in clinical trials to determine when you call a tumor progressive. It's not what I use in the clinic. We don't ever talk about the percent growth by RECIST, which is the criteria used in clinical trials. That was done as a part of clinical trials because you have to objectively measure whose tumor is growing and whose isn't. You don't have to do that when you're sitting in front of a patient in clinic. And I would say that you should not do that when you're sitting in front of a patient in clinic.
That's great.
Yeah.
I would just add some radiologists who, depending on the institution, might still use that as identifying growth in their notes, right? Of course, the provider looking at the scan can judge for themselves and make their own conclusion, but it might not be emphasized depending on the radiologist, in my experience.
Yeah, but what I would say is that 20% threshold is from clinical trials. It's not meant to adjudicate what you should do for a patient.
Yes, yeah, understand. Thank you. Lynn, did you have additional questions which you saw?
So you guys, yes, so you guys just finished your discussion questions. So let's go on to a couple of the audience questions. Dr. Ratan, it looks like there were some that you already answered in the Q&A. Are there any others? This actually you might not have touched on. Desmoids are not malignant, so how does someone end up with more than one desmoid at once if they do not have FAP?
So I think we sort of did touch on that. I tried to answer it, but I'll say it again. There's two possibilities, right? So one is multifocality, which mostly means that you've sort of got a webby tumor that's got mass-like areas, but then projections that you don't see as well. So it's all these tumors in one part of the body are connected, but those connections are not always apparent. So that's kind of that speaks to that locally aggressive nature of this disease in some patients. There are some patients where that doesn't fit either. Someone's got a tumor in one hand and then the other thigh. That is uncommon in desmoids. That is a patient that I will run into once every few years. I don't have a good explanation for that, but I know that folks like you are out there. And I wish I could tell you exactly what is happening, but I don't know.
Here's another one. Is the term cancer reserved exclusively for malignant tumors, or could desmoids be considered an
You are
Yeah.
muted, Lynn.
That's right. I cut the last bit of that. So I think, what we call a cancer and what we don't call a cancer is sometimes very tricky, especially with these intermediate tumors, right? So, we say it's not malignant, it's not going to spread in the bloodstream, and in that way it's not a cancer, but it can cause real problems for patients. It can be life-threatening. Some patients deal with it for their whole lives without adequate tumor control. And the place where I struggle with this is, the patient has an insurance product that says they're going to cover a cancer diagnosis. What do, right? How do you sort of parse those? And I'm not gonna offer a solution because I don't really have one. But sometimes our words are inadequate for sort of describing the experience of a patient, and that complexity is difficult to surmount sometimes.
Okay. Someone else is saying, I often believe that if it were considered a cancer, that insurance companies would be more willing to approve treatments. Do you think that desmoids will ever be, I guess you'd say, reclassified as quote unquote cancers?
So one thing I will never do is speak for an insurance company and tell you what they will or will not approve. Um, I think that uh, everybody sort of responds to the incentives that they're given, and we'll leave it at that. What I would say is that we use some very resource intensive therapies in desmoid, right? So for patients that have a desmoid diagnosis, there's a recently FDA approved therapy called nirogacestat, which is incredibly expensive. But because it's well studied and because it's in the guidelines, when a patient is diagnosed with a desmoid, it is typically covered. I have rarely run into issues with that in recent months. And part of that is that when we are sort of describing the diagnosis, one of the joys of my job is we actually code the diagnosis. And there is a coding system now which actually flags desmoid tumors as different from other connective tissue tumors. That wasn't always the case. The DTRF had a part in that. Um, and so I don't run into issues with that. Similarly, for some of the other medical therapies, some of which can also be pricey. Generally speaking, people understand what a desmoid tumor is, sort of in the institutional sort of insurance context. Where I see issues is for things that are on the cutting edge. Cryoablation will sometimes have issues getting that approved. Occasionally radiation, although less so, because those are still considered not quote unquote standard of care, although who defines what is standard and what is not is still not something I totally understand, because we do a lot of cryoablation for desmoids and there's a good amount of data for it. So we don't get everything covered, but I don't think it comes from whether it's a cancer or not. I think it comes from whether whoever's deciding whether the evidence base is adequate, which is typically the insurance company, thinks that therapy can be applied to desmoid. So I don't know if the cancer thing would change that or not. I won't speak for the insurance companies on that. But what I would say is that there is a diagnosis for desmoid, and that does then sort of inform what is covered.
Hey.
And you touch it, but I can just add that, so I worked in coverage policy back in my career, but the more research that you have, and especially high quality research, will only benefit, coverage of things because, if you've got some good results in a good trial, they're much more likely to cover something like that versus something that doesn't have a lot of research support for it.
Okay. Thank you so much. Thanks to all of you for joining. I want to thank our attendees. If there are any questions that anyone has that is not related to classification, please feel free to email DTRF at info@dtrf.org. We will we will speak to your questions as well as we can, or direct you in the correct direction to get some answers. And I just want to take a moment to thank so much our panelists today, Dr. Alex Omaya, Dr. Raveen Ratan, and Tian Sorensen. Thank you all so much for joining. This was so helpful. And I just want to thank the community for being with us this afternoon. Just again, after being formatted, this broadcast will live in our video library on dtrf.org. Please don't forget to sign up for our newsletter so that you will be notified when we post it. And we wish you all a wonderful afternoon. Thank you guys so much. And we'll
Thank you,
speak soon.
everybody.
Thank you.
Thanks for having us. Take care, everybody.